Welcome to Cold Steel, the Canadian Journal of Surgery podcast, with your hosts Omar Farooq and Chad Ball. The goal of the CJS podcast is threefold. The first is to highlight the best research currently being completed by Canadian surgeons. The second is to offer educational topics for both surgeons and trainees alike. And most importantly, the third goal is to inspire discussion, thoughts, creativity, and career development in all Canadian surgeons. We hope you enjoy it. On the podcast today, we have the privilege of chatting with Dr. Omar Farooq. Omar is much more than Amir's dad. His story of immigration, medical training, and raising a family in a new country is both inspiring and motivational. The aim of this podcast was to discuss some of the challenges that international medical graduates face. More specifically, Dr. Farooq provides insight on how to potentially navigate many of these hurdles, maintain a productive mental outlook, and ultimately to succeed. We'll let Dr. Farooq tell you his story. So, Dr. Farooq, thank you very much for joining us on Cold Steel. It's an absolute pleasure to have you. This is a really special edition, I think, of the podcast, and something we've been thinking about for a very long period of time. And we're really, really privileged to have you participate and help us out with it. Our goal really was to understand in a more nuanced way the international medical graduate experience within the surgical world, and see not only what that was like, but also how we can improve and how we can help the pathway of some folks. To start us off, then, I was wondering if you could tell us about where you grew up, when did you come to Canada, and what your particular training pathway was like.
Chad, first of all, thanks very much for having me on the program. And I really believe that the privilege is actually mine that I could be invited to such a forum, because, I feel that the pathway that I have taken, I'm sure lots of other people are going to be taking. So I think if I can facilitate that through your forum, I think it's a big honor for me. Anyways, I grew up in Pakistan, which is in Southeast Asia. I was in States, so when they would ask me, so where did you come from? I'd say from Pakistan, and they would always say, oh, that's that state close to Pennsylvania. I said, no, that's in Southeast Asia. So I grew up in Southeast Asia. I did my medical school from there. And in 1988, I decided to come in here. And I'll never forget that I landed on 14th of February. It was a cold day. And, when we were coming on the plane, that's why I remember the date so well, they were handing out flowers. So, my wife, who's born, has lived all of her life in Canada. I said, why are they passing flowers out on the plane? And, they told me it's Valentine's Day. So that was my introduction to Canada. And I landed in your city, Chad, and it was just all snow. And I was wondering, what is going to be my next step, in which the only thing I could see from up on the sky was snow. I then went ahead and did what most IMGs do, upgraded myself, wrote my exams, went to Cleveland actually, because I wanted to do surgery, but I thought, the Achilles tendon for a surgeon is always medicine, as you know, double-blind study is two surgeons looking at an EKG. So I didn't want to get into that. So I thought, might as well go and learn a little bit of medicine. So I got lucky enough and had the privilege of being in a very good hospital in Cleveland. Did a year there and got a breakthrough and came to Saskatoon, Saskatchewan. Did my 5 years of general surgery there. Went back to US because I wanted to go back to Pakistan to do cardiac surgery there. So I actually went to South Carolina, Medical University of South Carolina, did about 9 months of cardiac surgery. And after doing a few pumps, I knew this was not for me. Came back, did 1 year of laparoscopic fellowship at McMaster with Dr. Anwari. And then came to Fort Saskatchewan as a community surgeon, and have been there for about 22 years. Never looked back.
Wow, that's an amazing voyage. Just broadly speaking, and then maybe specifically, if you think it's helpful, what were some of the dominant obstacles? Maybe both in terms of, your initial medical training, as well as just potentially psychologically and socially when you first came over, and then in
Yeah.
particular as you pursued that really complex and high level training career path.
Okay. Chad, I think you hit it. That one word is so important, the psychological part. The mindset was my biggest obstacle. For me, there were two transitions. One is I was moving from one part of the world, which was very different from the other part of the world, which may not be true for all IMGs. Some IMGs are actually um, in Canada. They go and train and then come back. Mine was a different scenario. I had two things to become familiar with. It's just like anatomy, right? If you'll have to know about a little bit of brain and a little bit of abdominal surgery both at the same time, within a limited period of time. So, for me, I came up with a perfectionist mindset, and it was obvious that when you are in a new place, perfectionist mindset doesn't work. You have to have a growth mindset. So, if I had to say that what was my biggest obstacle, the biggest obstacle was myself. Um, well, I'll give you a small example, just to get into a residency, I didn't have people telling me that, you have to actually apply into a program. When I passed my exams, I thought, yeah, you know what? Why don't I just go and try out things as we do in Southeast Asia? If you wanted to do something, you just go after it. So I actually got a ticket from Greyhounds and drove into US without an interview. So the first guy looked at me, he's like, "Are you crazy? What do you think you're doing and looking for an interview?" But the second place I landed an interview, and that was my home for a year. So I think mindset is the real thing, which was my most dominant obstacle. I myself was the biggest obstacle. And that also put me in a mindset that in order for me to do better and to contribute, the biggest obstacle is also going to be me, because as soon as I got into a training program, the language was different. Right now the language is dude. At that time, it was a different words that I couldn't understand. So my thing was, Chad, I would call my wife and I said, this guy is saying this to me. What does it really mean in this terminology? So the language aspect of it, and I'll give you a small example. When I'd go for my rounds in the morning, we'd, in Pakistan, where you go, you shake hands with everybody. And so here, the residents were nice enough, but after about 5 rounds, they said, like, we don't shake hands, let's get to work. So it was a little bit of adjustment of a culture, the language barrier. But like I said, the most important part for an IMG who's actually migrating, that he has to sort of leave that cultural package behind. Not that there is anything wrong with that, but in order for a person to do well, he has to understand the norms of where he's operating on, whether it's in the abdomen or whether it's in a society. He has to constantly find out what the new thing is. So in a very generic way, that was the problem. In a specific way, I was not used to computers at that time, so I had to learn that.
Sometimes I think being an IMG, contrary to what most people think, actually conveys some benefits. Like, I think it allows you to maybe see things differently than other people see it. And there's also a certain sense of family that you see among IMGs. Like when I see, all the Pakistani residents, they're tight. Like their families are tight, they're tight, and they have a different sense of having kind of gone through this journey and this whole uphill struggle that no one else will really understand except for them. So do you think there's been any benefits for having come from Pakistan and then started training here? And do you think there's a special kind of camaraderie that links other IMGs together?
I mean, that's a great question. But retrospectoscope, as you know, is perfect. When you do an appendectomy, you can always say, well, you know what, I could have done it differently in that time. But when you're actually going through somebody who's got a BMI of 46, and that's what it seemed like at that time, that you're operating on somebody who's got a BMI of 46, you're going to easily get lost in the momentum there somewhere. At that time, it doesn't feel like camaraderie, or it doesn't feel like you have a definite advantage. Your mindset is very different when you come in as an IMG, because there's a lot of stress. Because people from where you're coming in and joining in have expectations. So stress management. So that your success is on the other part, on the other end of stress. So one thing that one doesn't realize, that for an IMG, stress management is actually a very important part, because he has to manage stress. He's sometimes coming from a background that everything looks new to him. You take somebody's language away and you bring him down to a zero. And this camaraderie among residents, you find camaraderie only when it's a strange analogy that just came to my mind. It's like, if there is one goat and there are 10 lions going after it, you have to figure out, are you the goat or are you the lion? It becomes very different. So it's like 10 IMGs going into one residency spot. And only one person is going to get what you get. As soon as the kill is over, everybody comes and joins in. So when you saw me, it was all of us were residents at that time. That struggle that went in. So the camaraderie among IMGs is because, again, the mindset. I believe in a different mindset. The mindset is that of, and that is pervasive also, right? It's the economic mindset of scarcity, that we have limited resources, and there are only a few spots, and only a lucky few are going to get it. So it takes you into a mindset that it becomes very competitive. So rather than helping people and using those 2 years of your life or 1 year of your life to get into a program to help each other, it becomes like, you were in a jungle trying to make a kill. So afterwards, like I said, it's a very serene kind of atmosphere and everybody's nice. But what you're not, that's the tip of the iceberg. What you, enemy, that's something that only an IMG can experience. The guy who did not get that job, who's still driving a cab or still selling a pizza, and still filling up gas, he has very different emotions about the camaraderie. He still thinks of himself as, he basically loses his own self-dignity. So he not only, of course, loses his skills. If you don't operate, you lose those motor skills. So he loses on many different ends. He loses his skills as a whatever he's trained in, but more importantly, he loses his confidence. And when you lose your confidence, that string that holds everything together, it's an integration. So I would say that camaraderie that international medical graduates experience after they have done residency and before they have done residency are two very different things. So it's not all rosy when you are going towards that. But once you are in that, beyond that threshold, it's very different.
That's such a profound series of comments, Dr. Farooq. And, it's an interesting time, of course, and maybe we'll get into it towards the end. But, as now a middle-aged white male who certainly would be described as privileged growing up in Canada, certainly I was on the personal, my family was on the lower socioeconomic side of things. I am aware of some of the struggles that you speak of, that I never had to deal with at any point, but certainly not all of them. And it's remarkable to hear that point of view. As a greater country and a medical community, and in particular a surgical community, of course, now that you've been part of for a number of decades. How do we make that experience better for an international medical graduate trying to navigate that pathway within Alberta, within Canada? How do we gain more insight? How do we show more insight? How do we be more helpful for those particular folks who, maybe have that aptitude and that drive and are going to be wonderful contributors to our medical landscape?
Chad, first of all, I think the most important part is again having a mentor, and I think if first of all the criteria of who can or cannot come in has to be as stringent as possible. You are up there in training residents, and we always feel proud on saying, I'm only going to let that resident go who can operate on my mother or my wife. So that criteria always has to be there. It doesn't matter whether you're an international medical graduate that you're trying to help. The bottom line is that the criteria has to be met, that this person is smart enough and trustworthy enough that you can let one of your loved ones gets operated on. So that formula that the Canadian surgeons apply, and I think surgeons apply that all over the world, is the golden grail. There is no question about it. That has to be met. Having said that, what I didn't know, Chad, was the research aspect of things. So if I would have come in and somebody would have said, you have this 1 year that's vacant, that's you're sort of trying to figure out what the next step is. If somebody would have just taken mentorship, or if there was a program in which I know what an avid researcher you are, for example, and if there was an avenue I could connect with you, I think that would have been very helpful. The second thing is, now that I've been a surgeon, when I would go into the operating room initially, there is a very different perception. If a surgeon would shout at me, for example, or was throwing a tantrum, to me it really didn't affect me, and I thought this was normal. And if a foreign medical graduate or an international medical graduate that comes through, if he is sort of educated in this, that this is not normal, that he actually has to be nurtured like a small little tree, because he comes on with his own background of complexes. He sort of thinks of himself a little bit less than everybody, and then the reason then becomes important, Dr. Ball, because then he cannot contribute as much as his potential is. And that's the biggest thing in my mind, that if our community as surgeons can take all the small obstacles or the big hurdles away from a path of such a person and let him just nurture, you just don't, we both know that human potential is limitless. There is no such thing as impossible. But that person has to realize it himself or herself. So in a more generic fashion, if a program director or the surgeons who are involved can nurture a person, and especially an IMG, and just take the obstacles out of the way and concentrate on those things which he or she may not have enough exposure, which I think is a research mindset. I think it will go long ways.
One of the things that people widely perceive as potentially getting a foot in the door is to become a clinical associate. And just for context for our listeners, the clinical associate program in Alberta is a program by which often IMGs are employed within a particular specialty, often surgical specialty, but also internal medicine as well, where they can practice as almost like as a resident looking after a particular service. Abu, what are your thoughts on being a clinical associate? You and I both know kind of sometimes how clinical associates can be treated, but on the flip side, sometimes it does seem like it maybe is a foot in the door for people. What do you think? What are your thoughts on the clinical associate program? Do you think that that's something that is good, or is it kind of exploitative for IMGs?
Mm-hmm. I mean, again, when you are looking for light and you even see a little glimmer, you hold on tight, right? So clinical associate program, I think, is definitely a big benefit. But you know how you always judge a program by what the end result is, what the end result. If for listeners, we are in Alberta. If Alberta Health end goal is to get a clinical associate to a point in which he or she can apply for residency, I think it's a great idea, right? And for somebody, on an average, I don't know whether you're aware of not, a clinical associate gets paid $30 an hour, which is, they have really cut down on it. And so clinical associate, for a person who's getting in, if that's the end of his career, that he is going to die as a clinical associate, well, obviously I don't think that's like, for that person, that may not be a fulfillment of his or her dream. But if there was a pathway in which clinical associate could gets into this program, and then has the ability to really shine, and other people can see that this person has potential, and then apply into a residency program, I think that would be great. So I think it's better than having nothing, but I think the goals have to be defined very clearly. So, in Quebec, for example, as you know, with this COVID, they have asked people to come in and apply for jobs, which are only going to be there till the COVID ends, and then it's all over. So, it doesn't take a rocket scientist to figure out what that clinical associate is going to be doing. That's a step in the door for him, but at what cost? Well, that person has to decide. But the analogy that comes to my mind again, the Mughals used to have those big knives, which were very carved, and which had emeralds on them, and lots of jewels on it. But if you use that knife to cut onions, it's not really a smart idea, right? So if the clinical associate thinks of himself that this is it for me, it's like using that knife that could do lots of things, and you're just cutting onions with it. So I think the end goal of this clinical associate program for people like Dr. Ball is very important, because they look at it as that here is a stream of fresh minds and smart people coming through, but then people higher up who are in residency programs are actually looking for these people and saying, okay, this guy can help Canada and can help progress the art of surgery.
That's really interesting. We think, as you do, I think a lot about the clinical associate program here in Alberta and the delivery of it. And I think your points are so dead on. I think that program probably is just like all the rest of life, in and outside of medicine. Life is sort of a bell curve, and the folks at the very top end of it who utilize that platform and that exposure to people and are real stars, they tend to walk into residency programs, as you're saying. There's a small cohort at the bottom of the bell curve, really, that maybe are a long, long way away from being able to contribute in that way, even in the near to mid future in the country. But I do worry about that program and that concept, and you're sort of highlighting it for the bulk of the bell curve. And I always sort of reflect on my connection with South Africa. I credit Cape Town and the trauma world in South Africa with a lot of my training, in that old school British system, as you probably know, it's quite interesting because you can be stuck as a same year resident for many, many, many years and not progress. And I always, when I first went down there as a resident to train for an elective, I'd never seen that system, and I was sort of blown away that it even existed, because certainly, in North America, certainly in Canada, you move forward, you have attainable goals, you make them, you don't make them, but you know where you sit. And I do worry that same sort of mentality or maybe reality applies to the bulk of the bell curve for folks in the clinical associate program, to the point that I wonder, exactly how much we are helping them or inhibiting them at all. So I guess my question, after droning on about that, is the psychology of that, of being stuck in feeling stuck in one place, must be, like my South African friends, just terribly demoralizing and difficult to deal with. How do you, not that you maybe ever personally experienced that aspect of it, because you're clearly a star from the beginning, but how do you deal with that? How do they deal with that? And how can they break out of it potentially?
And you're dead on again, Dr. Ball. But it's the same thing as Viktor Frankl. While he was living in Auschwitz, it's your mindset. He first of all, he knew that this was going to be a long struggle, but he only concentrated on those things which he could change. Because you're right. Once the hope is gone, you as a person sort of, disintegrate at many different levels. Some do it in a big way, and some people just, if you lose your dreams, you lose everything, I think. And you are absolutely right, Chad. Sometimes, like you mentioned about South Africa, and I know in Pakistan also, the system just helps a few people, and for other people, there's just total loss of their dreams, and they are just stuck in that system. Now, what is the solution for that? I think the solution for that, again, is that those people that there has to be a program for those people who are in there and not able to get off there, that there has to be, and again, I believe in research so much that I think, first of all, I don't want to use the word study, but we actually get those people involved and say, okay, what are the other areas that you can contribute? So, not everybody can become a star trauma surgeon, but everybody can write the economics about medicine. So, those people who are there, maybe medicine was just a foot in the door and for them, and, now they are in Canada. Because Chad, again, if you go in a mind of an IMG, there is a lot more social aspects of why that person became a doctor in the first place. Because I really believe that if you love something, you will get to the top of it. So that's the passion that drives.
Yeah, that's perfect. And you preempted, a concept that I really wanted to talk about, which is exactly that. When things aren't going well, how do you reintegrate and rekindle your passion or your movement forward? One of our listeners who's a close friend of mine, he's an HPB surgeon who most of the HPB community knows quite well, and I won't say his name, but he came over from his country as an IMG, and he was literally the janitorial staff in the hospital. That was his entry point. And work, and then he hooked up with an HPB surgeon who ran a lab, sort of befriended that HPB surgeon who had been in that facility for a long time, ended up transitioning into the lab, ended up transitioning and redoing medical school, residency, fellowship, and then now obviously it's a very successful and really great guy in that field. And I look at him and I'm amazed by the story and impressed by it, and he's such a beautiful human being. But I do also recognize, a guy with that kind of drive and that kind of hidden talent, at least hidden initially to people around him, he's going to do great. He's going to be a star because he has the same qualities that you do. But I do continue to worry about, the folks maybe who aren't as driven or optimistic or talented in these programs, and I worry about it, quite honestly.
Chad, again, that speaks more about what your prospects about, your perspective on life is. And, in the end, it comes on to, how much, what percentage of your own internal uh, uh, aspects that you get to rediscover. I don't think that there is any shortcut to that. I totally agree with you.
One of my favorite stories growing up is the story that we would always hear about when you first came to the U.S. and to Canada, where you have to write the LMCC exams, or sorry, maybe it was the USMLEs that you had to write. In any case, you met this another Pakistani who had been living in Cleveland for years, where you were doing your internship, and you told him, "Well, I'm planning to write both my USMLEs in the next year, write one sitting." And he said, "Oh, you're crazy! Like, I've been studying and trying to do this exam for years, and I've failed." And you told Mom that, you know what, I'm going to give it one shot. Otherwise, that's it. I'm going back. How much do you think the fact that you had us and you had a family kind of changed your motivation? And obviously you're not unique in that. Lots of IMGs come to Canada with a family, and that's often, I think, the reason why many IMGs come to Canada is looking for better opportunities for their family and for their children. But how do you think that, knowing that you had 5 of us to look after and to think about, how do you think that changed your perspective? How do you think that motivated you in a different way? And what advice do you have to other IMGs who have families and are trying to raise their families in a new country, while at the same time themselves going through this tremendous journey?
As far as family is concerned, of course, in medicine, I really believe that you need to have a partner in life that can take care of your kids, just because it becomes exponentially hard, or the person has to be so motivated that he or she can do surgery or do medicine and then come back and take care of the kids. Both aspects have to be there. For us as IMGs, the first thing I think for an IMG who's going through, remember what I was telling you, that there is always that stress component that happens. So the most important thing that I thought that I was never going to think about myself as a victim. And that mentality that, whatever I have to do, if I have 5, or 2 or 3 kids at that time, I really felt that was a strong point for me, not that motivated me to go out and do things. And again, at that time, family becomes important because it's not really about medicine or surgery at that time. It's how you control your stress that goes with it, because you're not getting anywhere, at least for initial period of time. And when you come home, you look, it may sound like very cliche or a movie scene, that you see your kid laying there and you're saying, like, how am I going to feed them, or what's going to happen? So, it becomes a reality at that time. It's not really a movie scene. It really does happen that, you see your kids and you get motivated every day. One other way that we can connect together with international medical graduates is having their families integrate themselves, because, the struggles are the same. In residency, you always have a grunt room, in which you complain against people like your professors, like Dr. Ballins, he did this to me, he did that to me. And, you can all get together and say, well, you know what, these are the struggles I'm having. Somehow once you release that struggle, it becomes, and somehow you feel like you've vented everything and you're ready for the next day. So I think meeting together with families, having a clear goal. The most important thing is not get into that victim mode that, I have these kids, what's going to happen to me? You just use this as a motivation, not as an obstacle.
Abu, you've kind of touched on this a little bit already, in that I think it's so important to actually have a mentor or a community. I always think of that story that you tell where when you came to Cleveland, then we made friends, or you made friends with other Pakistani doctors, and someone just offered out of the blue to edit your CV. Like they said, literally, just send me your CV and I'm gonna go through it without you even asking them to do it. And they totally revamped your CV and made it possible for you to go and apply to surgical residencies. So beyond having reaching out and becoming part of the community, are there any specific resources that you think are important for IMGs to know about? And what would those be?
I think the most important resources is people. I really believe that for IMGs, connecting with people, along with their community, is really important. But I think Amir, for IMGs who are coming in now, the resources are all available on the net, if I may use that word. I think it's not about the availability of resources, which is there. I think there is a big distinction between knowing something and having knowledge of something. So although the resources are there, I really believe that it's in small steps how an IMG uses those resources and gets to where he or she wants to get to. So I think it's not about resources. It's, again, being able to cultivate those resources in oneself that I think is important.
Dr. Farooq, your insight and your humanity, quite honestly, and your advice is we can't thank you enough for it. And I think this podcast is going to do hopefully a lot with our international medical graduates. Obviously Amir and I have been doing this now for many months, and there's been a few world events that have occurred while we've been doing it, and it would probably be remiss if we didn't touch on it. And certainly the global call for quote unquote visible minority equity right now is clearly very, very front and center. I guess I'd like to end the podcast with your views on that. It seems a little bit funny to apply this label to you because, of course, you've been in Alberta as a staff surgeon for so many years. But I guess as a visible minority, as a surgeon, as a father, as a husband, as an international medical graduate, and as a Canadian, how do you view the current equity discussion that's going on? How do you process it, and what do you think about it going forward? Not only in the U.S., where yourself and myself and a lot of us have lived, and it is a different place, but in particular as applied to Canada and maybe even the medical surgical world.
We have forgotten as surgeons our role for having this equity distribution. And who are better people to understand this than surgeons, right? When we cut a person, we know that the blood is always of the same color. The gallbladder always looks the same. When you're doing transplants, you don't match by color. You look at HLA, and at that time you don't have that distinction. So we know as surgeons that this is such an arbitrary division of color. When you have a bleeding vessel, you deal with it very differently than how you deal with a chronic wound. And I find that this racism problem or this color problem is, one should deal with it at all aspects, just like surgeons, operative way versus non-operative way. Because, life for me, being as a surgeon, honestly has become so binary that it almost feels like, okay, what's the operative way? What's the non-operative way? So I would think, if you just think of it as a preoperative assessment, I think one should just as surgeons, even if we contribute $10, first of all, if we think that that's a problem, just like we have given up hospital administration. I know I only complain about it, but don't contribute towards it, because I always feel like this is not my problem. So the first thing is realizing that it is a problem and we have to deal with it. I think that in itself will go a long ways. And who else can deal with it better than people who see blood every day, if you know what I mean. So even if we contribute like, $10 in an area that we decide, First Nations come to mind, other minorities come to mind, that we are going to support 10 kids in a year. The surgical community, I'm not talking about Canadians specifically, but generally. And in our community, we are going to have pathways for these 10 students. We are going to facilitate that these people have role models, and they can actually, all the hurdles that come for this specific background are dealt with. I think that's the first thing, that we start at a very basic educational level. And then, that's sort of the preoperative assessment. Intraoperatively, sometimes like, you have to stop, you have to put pressure on the blood vessels, and sometimes you have to tie it. Sometimes if the area is gangrenous, you just have to take it off. So that all intraoperative approach, or the current approach that happens, you have to take it event by event basis. Sometimes you have to, and your discretion, your own biases come at that time, how you're going to approach that particular thing. Basically remembering who we really are as human beings and as surgeons.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.